Welcome to those of you who are in the room early on a Sunday morning here in Montreal, and to those of you that I see online already, welcome. My name is Anna Grimsrud. I'm a Senior Technical Advisor at the IAS, and I am very happy today to be filling in to support this satellite session, where we're going to talk about getting person-centered care right, good practice models of integrating HIV and other health needs. In this satellite, we will provide an introduction to person-centered care and share good practice models of person-centered care, featuring implementers from various settings and regions. And that's really what we're all here to do today. Really excited about the panel and the presentations that we're about to hear. I have no conflict of interest. So here, I'm going to introduce our speakers, and then I'm going to let them do most of the talking. Our first speaker is Brent Allen from ICASO, or the International Council of AIDS Service Organizations, Australia. Brent will present on the conceptual framework and considerations for implementation of person-centered care to ensure quality of life for people living with HIV. Next will be Tung Don from Lighthouse in Vietnam, and Tung will present on the peer-led and one-stop clinic model for young key populations and young people living with HIV in Vietnam. This will be followed by a presentation from my good friend Baker Bakashaba from TASO, or the AIDS Society Organization in Uganda. And Baker's going to present on TASO's person-centered care model for adolescents and young people living with and affected by HIV. Our fifth speaker is joining us from the Philippines, Rodney Olete from Gambay Se Pulong Lasso, and he's going to present on the temporary shelter program and supportive expressive group therapy, or SEGT-based psychosocioeconomic support for people living with HIV in the Philippines. And then last, but definitely not least, is Daisy Kwala. She's here from Kenya today from the Bar Hostess Empowerment and Support Program, and she's going to present on their person-centered care model for sex workers who use drugs in Kenya. So this is our run of show. You've now had a chance to briefly meet our speakers, and we really look forward to your discussion, to the discussion and questions at the end, and so I kindly request all our speakers do their best to stick to their time allocation. We also would like to hear your thoughts about this session, and we hope you'll engage and interact with us both in the room, online, and via social media. And without further ado, I will hand over to Brent. Thank you.
Great. So it's my pleasure to join you this morning after making sure that I wore no pants last night at No Pants, No Problem. A great party, the last one, celebrating the diversity that comes from this fabulous conference. My acknowledgements, to begin with, and I think this is important for all of us, by thanking everyone living with HIV, those who've generously shared their time and experience, perspectives for the purpose of this project. Much of the fight against HIV relies upon people living with HIV to continue to put themselves forward, and this research and our fight against HIV is indebted to those both past and present. I do have a conflict of interest. I've been working for the past year with the National Association of People Living with HIV in Australia through a ViiV Healthcare Australia funded grant, an unrestricted educational grant, and I am the co-author of a manuscript on client-led care that was funded through an unrestricted educational grant by Gilead. So to begin with, as I said, been working over the past year with the National Association in Australia to interrogate and think about deeply what it means to have a quality of life for people living with HIV in Australia. We have the pleasure of having a really incredible tool developed in Australia, then I encourage you to seek it out worldwide, called POSQUAL. POSQUAL is a 13-item tool for domains that look at quality of life. It's a tool that can be used in community settings, in clinical settings, and what it does is allow us to create benchmarks and measurements against quality of life. And we've used this tool over the past year to determine what it is that people need when it comes to a quality of life. Yesterday I was in a session and we talked about the three things that people need around person-centered care. And in particular, we talked about what they need to see, what they need to hear, and really importantly, what do they need to feel. And this project very much is a focus on how people feel about their life. So as I said, over the past year, we did an incredible amount of work through hundreds, literally hundreds of people across Australia helping to do this. We had Sunday socials online, town halls, we had webinars, published a really great manuscript in population medicine. We had presentations at our National AIDS Conference, all of which were inviting people to talk to us about their quality of life. This wasn't us telling them about what they needed. This was our attempt to dive deep into quality of life because we know that this is something from a person-centered care experience that is critical to their not only the quality of their relationship with their healthcare provider, but their quality of life overall. Two of the outputs of the project, I encourage you to see these. These are both posters. One is around Peers Explain, where we've used Peers as a knowledge translation tool to look at published works and talk about this work and the findings in the language and the terminology and in ways in which the consumer, our audience, our community can understand. The second is a really fantastic resource. We invited an HIV positive artist over the course of a year to help us understand what AusQual could look like if you saw it visually. And so they sat in on meetings, they sat in on these webinars, and over that they created this catalog of work. I really, personally, I'm very fond of our first piece, which is Poly, the polypharmacy dispensing machine. Which really speaks in a graphic and illustrative way what it means around polypharmacy and what it means to people. So these are just some of the products that came out of this project. All of them, I think, really interesting around putting the client, the person, the patient at the center of the work. But this is where the real guts, the real joie de vivre of the project comes from. This is a poster, again, here at the conference, authored by Daniel Reeders and myself, around what it is, this framework around self-perceived quality of life. So as I said, hundreds of people from across the country spoke to us about what their quality of life needed to look like. And it was their self-perception of their quality of life. I kind of like the accordion diagram, but we've also conceptualized it as a flower with petals and everything. But if we look at the accordion diagram, what it is we saw that there's the person at the center, and then there are positive forces and negative forces that, like an accordion, move and contract and open and close over time, depending what they are. The drivers are seen there down below, positive drivers being meaning, belonging, care, and support, negative drivers being isolation, stigma, distress, and inequity. The output of AusQual, which is published, and the framework itself is available for everyone, is calling for a quality of life for everyone by 2030, living with HIV in Australia. And we are encouraging everyone, regardless of their position inside the response to HIV in Australia, to think about the social determinants of the quality of life, to address comorbidities, healthy living, mental health, polypharmacy, treatment literacy, and chronic pain. These are the things that came out when we talked to people that are profoundly affecting their quality of life. To reduce stigma, isolation, insecurity, and distress. And when we talk about insecurity, we're talking about housing insecurity. We're talking about migration insecurity, living on a visa that is, I'm not allowing you, for example, access to healthcare. We want to enhance meaning, belonging, care, and support, both virtually, in person, through networks, through families of choice and families, biological families. We want to evaluate clients, patients, clinical groups, communities, and populations, and encourage measures to be set in all of those areas. But in terms of person-centered care, I want to take you one step further. And I want to talk briefly about not person-centered care, but client-led care. This is an option, I believe, for some people living with HIV who want to lead their care with their provider. It's a step beyond person-centered care. And client-centered care is a great thing, works for lots of people. In fact, for some people, as patients, they want to be told. That's what they're choosing to be. But some want to lead their care, and they want to do it in a way with the support and encouragement of their healthcare provider. This was the results that was in the published paper that you saw on the earlier slide. Again, you can see I love a graphic. It's really easy to read as a wheel, working in partnership. What are the things around information communication? How do you build trust with the end product being not person-centered care, but where the client leads their care? And the take-home message, a client-led approach can complement conventional HIV care strategies and enable empowerment and the greater engagement in care, potentially improving the care continuum and overall quality of life for individuals who can and want to lead their own care. So what makes a difference? The quality of the healthcare provider-patient relationship, acknowledging that, like the accordion, it changes and it moves over time, and that one size doesn't fit all. Next one. Next slide. Hopefully there we go. A shared understanding of the complexity of care between patient and provider. I was talking to a colleague of mine last night about how some people want there to be simplicity for everything. I think when we're talking about person-centered care, and certainly client-led care, we need to acknowledge complexity and thrive in the complexity, embrace the complexity, enjoy the complexity. And finally, our shared desire in terms of both quality of life and person-centered care to be happy, to be healthy, and to be connected. I'd want to thank so many people for this project over the last year. ViiV Healthcare, NAPWA themselves, my colleagues at Gilead as well, who helped with the paper, my Peers Explain colleagues, Daniel Cordner, who couldn't be with us here today, but is the artist who's contributed to this outstanding resource. Dr. Graham Brown, who here is in the audience, Dr. Lucy Stackwell-Moore, and Dr. Jeffrey Lazarus, who just inspire me to no end. And of course, my colleague and very dear friend, Daniel Reeders, who helped me throughout this entire project, and we helped each other. So I'm hoping that I can inspire you for questions. Thank you.
Okay, good morning, everyone. Again, it's very pleased for me to join this section and share, and very proud to share about the Lighthouse Community Clinic in Vietnam, a person-centered peer-led clinic for young key population and young people living with HIV in Vietnam. So I have no relevant financial relationship with ineligible company to disclose. Yeah, first of all, I want to introduce you a little bit about the Lighthouse. We started up in 2004 and officially registered as social enterprise in 2016. And in 2020, we opened our own community clinic in Hanoi to serve young key population with quality and friendly services. And as you can see on the screen, there are a lot of activity that we engage with our community in Vietnam. We are now focusing on 6 key areas. And we're trying to enhance the health, right, and development of the community, including educate and generate demands of community for the sexual health and HIV and AIDS services, build and deliver friendly and quality services, conduct the community-led research, and generate the evidence to advocate for the community rights. We also build capacity and empower community, and also mobilize and connect and unite the key population in Vietnam. Okay. Lighthouse is currently served for the whole young key population, but we really focus on LGBTIQ community. Okay. So to improve the efficiency and impact of our operation and services to the community, we adopt the strategy of the person-centered care in all of our community program, and we define the person-centered care is always listening to and respecting the client, caring and meeting the needs of each individuals in a comprehensive and appropriate way, and empowering people to take care of their own health and well-being, and meaningfully participate in improving the quality of healthcare for the community. So In here, why we applying the person-centered care in very overview of our models. That started from the problem that low uptake of HIV service among young key population due to unfriendly services. It's repeat and repeat again in many research and study and survey. And in overview, person-centered care at Lighthouse consists of 8 components. The first one, we adopt the community advisory group. The second, creating the friendly environment for our clients. Provide the high quality, we also have the high quality peer provider working with us and providing comprehensive and individualized services for the community. We also really invest in the client relationship to build the relationship with our client and also engage the client in all process of the services, including designing, development, and provision. And also increase the health literacy, especially for young and adolescents who are affected by HIV, also very important. And lastly, engage them in the monitor our services in quality improvement. Here is the building blocks of the services at Lighthouse Clinic. The table showing that we are not, I will not go into it in detail, but want to emphasize like how we integrate the other services besides the HIV services. We also integrate the STI testing and treatment, mental health care and screening, and also for transgender people, gender affirmation care, and also the harm reduction services for ChemSec community. And in this slide, gives you a clear view of our integrated services to community. We have COVID commodities, mental health, TB screening, and also other NCD services for the people living with HIV. We're trying to diversify services to meet the comprehensive needs of the community. And here is some quantitative outcomes. As you can see in the chart from September last year, since applying person-centered care, we have got very great result in number of people enrolled in HIV testing and PrEP and ARV treatment, as well as the STI and mental health services. And we also have some key takeaways, lessons. The first, person-centered PrEP service approach need to be tailored to different subgroups of key population. We have to diversify the services for young MSM, for elder MSM, and hard-to-reach KP, for example, like ChemSec community, providing a comprehensive and needs-based services package that helps generate demands of HIV services. The community, they need more than HIV. They need STI, mental health, harm reduction, sexual gender-based violence, hormone, and gender affirmation care, and it needs to be integrated in service package. Providing friendly, flexible service led by peer greater increase the uptake of HIV services. Mobilize the participation of key population in service that help to reach the hidden and high-risk community. And lastly, invest in customer services to make sure that we build relationship even after the use services at our facility, help to increase the retention rate of the services. And here we also have the result from our client anonymous survey, so nearly 100% among 561 respondents satisfied or very satisfied with our services in 5 key areas as included in our survey. The first one is availability and accessibility of the services. The second is welcome and service instruction process. The third one is attitudes and expertise of the medical staffs, and service delivery procedure is the fourth one. And the fifth one is client care services. I will not read it out loud, and you can read it here. In some of quotes from our clients talking about services when we adopt the person-centered care at our clinic. This slide once again emphasizes how that we apply the person-centered care and integrate HIV and the other health needs. For the next steps, we will document the Lighthouse clinic models and share widely to other community organizations. Regular collect the data of issue and needs of the community, because we know that it changed a lot in not only pre and post-COVID, but also in the coming time, there are a lot of things happens, and the needs of community will be very different, and engage them in design the new services and deliver methods. For example, for now, we have like tele PrEP and telemedicine, so we are thinking how we can integrate and also engage our client into that method. Continue strengthen and expand HIV services and make sure that we can provide the flexible services to the community. Integrate the harm reduction services, hormone therapy, and gender information counseling for the community. We also strengthen mental health care service, applying art therapy, peer counseling, and mental health friendly service map to the community. We found that community really needs some mental health services in the HIV service. Develop a platform for HIV service facility to exchange and learn about person-centered care and how to apply it in their sites. And lastly, advocate for the national guideline on person-centered care models in Vietnam. And in conclusion, I just want to raise the voice of community on the needs for the person-centered care. The first, person-centered care is important because everyone has the right to equitably access the quality health care. And it's also the right thing to do to ensure key population and people living with HIV to achieve the best health outcomes and well-being. And lastly, it's a vital approach to eliminate HIV and AIDS by 2030. Thank you very much.
Good morning, good afternoon, good evening. I'm Beka Bakashava. I work with the AIDS Support Organization in Uganda. And I'll be presenting a person-centered care approach for adolescents and young people living with HIV in our clinics in Soroti. I have no conflict of interest to declare. So the AIDS Support Organization is a non-government organization started in 1987 as one of the first indigenous responses to HIV scourge in Uganda. And our vision is a world without HIV and AIDS, and I'm glad that we are all here working towards that. So for this specific project, we are implementing a 5-year comprehensive HIV care, treatment, and prevention and health system strengthening project in one of the regions in Uganda. And this region has 15 districts and with a population of about 5 million Ugandans. The scope of work is broad. It has HIV prevention, care and treatment, TB prevention and treatment services, and health system strengthening. But with COVID coming on, we're also doing a lot in the response against COVID. So we serve a significant proportion of the population. We have close to 200,000 people under our care out of the 1.4 million Ugandans living with HIV. And these are in the Soroti region, but also the other regions where we offer comprehensive support. And this includes the adults, pregnant and breastfeeding women, adolescents and children, as well as key populations such as sex workers and their clients, men who have sex with men, and people who inject drugs. So for this specific project, for the young people and adolescents, peer supporters, the objective was to increase the proportion of adolescents and young people living with HIV who know their status, and also to improve ART coverage, but also to increase viral load suppression among adolescents and young people living with HIV. But most importantly, to improve the psychosocial well-being through provision of care and support. And as you can see, these participate in a broad spectrum of activities in all our clinics that we run. So this particular model, the YAPS model that I'm talking about, we've been implementing since 2019 in collaboration with the Ministry of Health and supported by PEPFAR that funds a significant proportion of our projects in Taso. And it was adopted from the Zvandiri model, the CAG model in Zimbabwe, following a South-South learning visit supported by the Sequin project implemented by ICAP. And I really appreciate that project. So we did a pilot with 5 implementing sites, 1 center of excellence, 1 health center, 4, and 3 lower facilities. And currently, we are scaling up the implementation. And to just give you an overview of this model, the target population is 10 to 19 year-old adolescents and young people 20 to 24 years. The peers are aged 18 to 22, the peer leaders who are formally recruited and facilitated to participate in the management of this subpopulation. So unlike previous programs where we're using volunteers, we do actually facilitate these. And that's why we use 18-year-olds and above, because that's the age of consent and where in Uganda someone can work. They follow the national adopted guidance, which we developed together with the Ministry of Health, that supports the entire continuum of response. And they participate in the performance review, in the design, monitoring, and implementation of this program. And part of the facilitation, we provide them bicycles to ensure that they move and are able to see their peers in the communities. And these are the building blocks: engagement of the leadership, where one peer leader works at the facility for 1 day, and then 2 days in the community. So for a total of 3 days, they're able to devote time to this work. And we also have additional workforce that supports these clinics. So where need be, we have healthcare workers that come in to manage the conditions that are required. They do follow up and support retention activities, both in the facility to provide counseling, but also in the community when their colleagues are lost. So there's a lot of play, there's a lot of play therapy, and we do encourage the peers to feel free, because it's then that they are able to communicate freely, whatever challenge they may be having. So the target is to address the complex health needs of the adolescents and young people. And this is a population where we've been struggling to get good outcomes. And it's multi-sectoral in approach. Both are the districts, the health facility leadership, and the peer supporters, and also integrates other conditions: NCD screening, COVID, gender-based violence, and also mental health activities. And we do link these to the OVC services. So some of the results that we've seen so far in the 2.5 years of implementation, we have about 623 active adolescents and young people living with HIV in the program in just 3 sites. Self-test kits are distributed through these initiatives. Improvement in the testing yield, because we are able to target better and bring in a lot more adolescents. And the linkage up to 100% of all those that test positive. And retention as well, especially through the follow-up activities. The viral load coverage has significantly improved from 84% to 97%. The same with viral load suppression, sorry about that typo, still from 82% to 95%. And then counseling is provided, as well as optimization, to ensure that all our adolescents and young people are on the optimal regimens. And clearly there's a lot of appreciation of this. And from one of the beneficiaries, at first they had difficulty accepting their diagnosis. And he did actually say he could not take those medicines well because of what people are saying about them and everything. But when they were linked to fellow young people in Tasso, they were able to be supported. And the person reports that he's now healthy and well, and he has a future to achieve. And for us, that's very, very important. Like I said, we do integrate services right from prevention, testing, linkage, and treatment. And they've been very pivotal in the COVID prevention and vaccination efforts. So our next steps, we plan to implement the APS model across all our facilities where we have adolescents and young people living with HIV, and working with other key stakeholders. This is being scaled up nationally, and there's already some commitment from the donors and the partners to fund this across many of the areas. We've had, in conclusion, we've seen a significant improvement in the outcomes, something that we struggled with for so long for the young people compared to the adults. And it's clear that this model is scalable, and that's what we are working on. And it has empowered young people to take charge of their lives and their health and the health of their peers, which we know is very sustainable and efficient in the long run. So we appreciate the efforts of everyone, the Ministry of Health, PEPFAR and CDC that funds the project, and all the partners that we work with. Thank you.
And while Rodney's coming up to the stage, I just want to remind people that following Rodney and Daisy's presentations, we should have some time for questions. So we will be taking questions from microphones in the room, as well as from those of you online. Feel free to start posting your questions. Over to you, Rodney.
Hello, everyone. I am Rod Olete from the Philippines. Forgive me for my voice. I'm feeling kind of under the weather because of the change in climate from Taiwan to Canada. I'm here to share the Open Doors Home program. It is an SEGT-based psychosocial economic support for people living with HIV in the Philippines. Psycho because we are promoting mental well-being, and then social because we are advocating for connectedness, and then economic because we also try to address all the economic barriers that a person living with HIV is going through. And with no conflict of interest to disclose, let me introduce our organization. So Gabay sa Pulang Laso is a Filipino phrase which means guiding the red ribbon. Known as GPLI or Gabay for short, the organization was founded in 2018 and got registered in the Security and Exchange Commission in 2019 as an official nonprofit organization. Our main goal is to ensure equitable provision of psychologic and other non-biomedical support for people living with HIV. We intend to attain this goal by protecting social determinants of health through psychosocial support, spiritual counseling, stigma reduction, and advocacies with the local government units. Now, for us, we interpret person-centered care that should be focused on holistic well-being of our housemates. By the way, housemate is the term for our people living with HIV who are under our care in the shelter program. Housemates are empowered to take control of their mental well-being and physical health in attaining their ideal quality of life according to how they defined it. Now, Gabay's person-centered care, as what you can see in our model, is focused on providing holistic care, emphasizing on non-biomedical needs. We believe that by addressing the economic needs, by addressing the educational needs, by addressing all the other barriers to achieving a quality of life, we would guide our housemates in attaining their ideal quality of life and improve their adherence to their ART and follow up with their clinic visits. So person-centered care in Gabay through the Open Doors Home ensures that individualized assessment of the physical and mental health during the shelter admission until they exit. While in the ODH program, our housemates are provided with the basic needs such as food, beddings, and toiletries. Excuse me. This also includes supportive expressive group therapy, or SEGT, which I will talk more about later. So if the housemates have finally expressed their readiness to pursue education or livelihood or employment, Gabay will always be there to lay down all potential options for them to carry over. If the housemates managed by the shelter parent, all the housemates are managed by our shelter parent. His name is Choi. He's an amazing person. He finished as a trained nursing care assistant. So our shelter parent ensures that we are complementary with the HIV treatment facilities and attaining viral load suppression among our housemates. The shelter parent takes time with the housemates and emphasizes the importance of adherence to ART and doctor visits for medical follow-ups. So just to go back a little bit, SEGT, I want to emphasize more, is a 1 hour per week group session over 12 weeks, over a period of 12 weeks or 3 months. Now, this includes journal writing, catharsis training, expressing their emotions, whether they perceive that it's negative or positive. We always encourage to express their emotions, and in this way, we would be able to encourage healthy acknowledgement of feelings. And we also use positive reframing, and we monitor their mental well-being through GAD-7, PHQ-9, and WHO QOL for the quality of life. Now, this is the entire implementation process of SEGT, which I will not go through. I will just focus on the process of going through the modules. These include the 12 particular topics that they need to go through, and then after that, they will be evaluated for the generalized anxiety disorder 7 questionnaires, and then PHQ-9 for depression-related symptoms, and then the WHO QOL brief. So just for the pilot data analysis of our 17 initial clients during the height of the pandemic, we have more than 50% of the housemates gained full independence after exiting the Open Doors home. The average of stay was 118 days, or 3 months and 27 days. More than half of them are referred to us by the CBOs and partner NGOs. And homelessness was the main reason for more than half of the client for admission. But this also includes those who experience domestic violence and also those who have experienced trauma from their own families. Now, I don't want to go through the entire numerical details of our data. It's just showing the noticeable decrease in mental condition, or should I say mental well-being. The GAD-7 and PHQ-9, there was a noticeable decrease, meaning that they improved their mental well-being while they are under our care. So the key takeaways from this SEGT approach is that there is a statistically significant differences in the PHQ-9 and GAD-7 scores during the discharge compared to the admission. And moving forward, these are the feedback from our clients. I will not go through it further. I just want to point out that majority of them believe that there was a positive experience while they are in our care at the Open Doors home. Now, this is one of the notes in the journal of our housemate before he left. He's just thanking us for allowing him to muster the courage to reconnect with his family, and then he's now back in his hometown. This is another testimony from one of our clients, one of our housemates, which you can check out more in our website. So person-centered care elements is identifying the needs of the housemates by the housemates, concentrating more on the social determinants of health as potential barriers to the quality of life after HIV diagnosis. And SEGT-based psychosocial support has the main goal of implementing more evidence-informed, peer-led support system among people living with HIV, while us, the healthcare providers, only serve as facilitators. So how do we integrate this to the already existing biomedical interventions in the Philippines? Psychosocioeconomic support would be integrated into local service delivery networks, or SDNs. HIV care providers extend to psychologists, social workers, and even the people living with HIV themselves to take control of their own health. SEGT integration in the HIV management improves emotional faculty of the person living with HIV, and ODH, or Open Doors Home, as a complementary approach to ensuring ART adherence and prevent loss to follow-up. So what's next for us? We are now developing a comprehensive implementation manual and then proposing our project to a national agency for funding as an implementation study. And then we are lobbying ODH SEGT to the City Social Welfare Department for scale-up. Now, in conclusion, Open Doors Home is currently the only SEGT-based temporary shelter support program in the Philippines. ODH is centered on psychosocial economic intervention, which are complementary to the already existing biomedical management in HIV in the country. ODH addresses other social determinants of health according to their perceived needs of the housemates in order to attain their own quality of life as they deem ideal. And with these, thank you so much for listening. And I would like to also acknowledge the help of our amazing president, Dan Chris Reyes, our shelter manager, Choi Rivera, for their wonderful job with our housemates. Thank you so much for listening.
Retention and all these indicators that work within the programs are only as useful as when the recipient of care is satisfied. And that's the only thing that can tell you that this will last, because if they are not satisfied, then what you see as good outcomes in form of viral load could drop in the next three months, because people are dissatisfied, they drop off care, off their meds, and down the suppression rates go. And we've made attempts to measure satisfaction on a regular basis, but I think we still have a long way to go. And now I do realize that we need to begin disaggregating for the different populations, because the needs are different. What satisfies the adults may not be what satisfies the young people and the adolescents and the children. And I think that's where we should be heading to ensure that we can sustain these gains. Thank you.
And maybe in addition, while we are so, while numerical values and quantitative measurements of quality of life is important for research, let's not also forget the importance of qualitative individual experiences of the people that we are serving, because above all of these numbers, there's life that is experiencing all of this. Maybe let's talk about their experience with their healthcare providers. Let's talk about their emotions about aging while having HIV. Let's talk about their connectedness with their family. And these are all contributors to an overall quality of life as well. So my point is that while we are advocating for numerical values, let's also not forget the lived experiences of our clients. Thank you.
Thank you very much. So that is well addressed. So I wanted to respond to the second bit of the question, that was how do we kind of guide conversations around person-centered care. So what I've seen worked for us in Kenya, we have like consultative meetings with the community and also just try to see what is working well and like what we can adapt into our systems. And also like we've said previously that COVID really affected us. So we were trying to see what can really work well to improve the health outcomes of our patients. And through this and through the focus group discussions that we've had, I think that informed the steps that we made in regards to person-centered care. Thank you.
Sorry. I also would like to respond to the second question. I think like we adopt the one-stop shop model, but it's not mean that we provide every services to our client, but we have to develop our referral system. So we also identifying like the other services is friendly for the community to refer our client to, and to ensure that we have the same level of quality in our system. So we deliver the like sensitization training for the healthcare provider there, and also to create the dialogue between our client with the health provider in that health center. And also we working with like Ministry of Health, BIAC, to develop the national criteria for KP-friendly models, for KP-friendly facilities. So it's guide the old facility who serves KP, if they want to be the friendly facility there, they can adopt the models, and they also can, you know, like improve their quality based on that guideline. So that is something that we are working on, the referral system, and make sure that community can involve in.
Great. So hearing lots of themes about how you can't do it all. You have to actually make the circle bigger and bring others along on that journey with you. And then on the metrics piece, I heard a quote yesterday about how it's not the only thing we measure, but it's the only measurable thing. And I think what you guys are kind of teaching me here is that you can measure quality, and we should measure quality, and it doesn't need to be kind of a rub with also ensuring that we have individual patient stories and journeys and changing hearts and minds through these narratives as well. So maybe just a last closing question here from Michelle online. Hi, Michelle. If you could all speak very briefly to how you balance patient-centered care with equity in resource-constrained settings. And you're all being so polite, so I don't know, like, yeah, you got 2 minutes left. Take the floor.
I think we were in a session earlier, I think it was yesterday there or the day before, about equity and accessibility and person-centered care. And I think that what the WHO did on the very first day in acknowledging the importance of peer navigators and peer support workers inside care models is critical. You know, and I wish I had said it in this meeting. I didn't, and I'll say it here now. Instead of thinking that your peer navigator is the last thing to bring into your care team, it should be the first thing you bring into your care team. far more cost effective, far able to take the load off the clinician in so many ways, better than almost any others. It's difficult to explain that, I think, sometimes to people in the global north, but I'd love to hear from you what we were talking about. It's an amazing way of doing work better.
Yeah. What I can add is that at the end of the day, patient-centered care has to be contextualized, because, like we know, some places are well-resourced, others are not, and therefore, what can be available to the patient. Take, for example, an element like multi-month dispensing. That can only happen if the stocks can allow multi-month dispensing for all the patients. So in a situation then where you cannot, you live within the means that can be attained. Of course, that then shouldn't stop programs, clinics, health providers, but also the recipients of care from aspiring for what is better and what is best. And I think that's why this conversation needs to continue, but also sharing across borders, across units, across facilities, because sometimes people are unable to aspire because they are unaware of what is possible. And I think when that information is made available, it becomes easy to have the conversations and raise the aspirations for both the health providers but also the recipients of care. Thank you.
Any last thoughts? Daisy, I see you.
Okay. So what I wanted to add was in regards to resource allocation, or maybe in the limited resources we've had, we've also worked within other models like differentiated service delivery, just to ensure that as we do other models, we incorporate the person-centered care approach for the better outcomes. Yeah. Thank you.
Great. So then all that's left from me is to thank our presenters. Here on stage are people that, with support the IIS is working with, to shine a spotlight on the work that they're doing, and we're really committed to doing more of this going forward. So, for example, we have a supplement in the Journal of the International AIDS Society that'll come out next year, focusing on person-centered care and driving forward the evidence base. And I just want to also make a flag that one of the guest editors from that supplement has a plenary on Monday, so we're glad to see person-centered care taking a more prominent role at AIDS 2022, and I'm sure you guys are the choir in this room. So keep the singing going towards person-centered care for the rest of the week, and thank you very much.